Hello there. So now we'll be studying about Gilbert syndrome. So here we have a 21-year-old man who has been brought to emergency by his friends as he's having a yellowish sclera and yellowing of the skin. He has recently been having flu-like symptoms, a non-productive cough. A urine dipstick was performed and it was normal. Blood results are hemoglobin is 129, reticulocytes 1.2, bilirubin 44, ALP 88, ALT 24, albumin 42. So the single most likely diagnosis is being asked here. So Gilbert syndrome is usually an autosomal recessive disorder, and it is a common cause of unconjugated hyperbilirubinemia due to decreased UGT1 activity, which is the enzyme which conjugates bilirubin with glucuronic acid. It may go unnoticed for many years, and it usually presents in adolescence with intermittent jaundice occurring during illness, physical exertion, stress, or fasting. In this, the jaundice was precipitated by infection. In this case, which we are seeing, the jaundice was precipitated by infection, and investigations usually show a mildly raised serum bilirubin, but the other LFTs remain within normal ranges. So only serum bilirubin is mildly raised. Other LFTs are within normal, as seen here. And FBC would show a normal reticulocyte count, which helps in distinguishing Gilbert syndrome from the other types of hemolysis. Urine dipsticks would be seen as normal, as it is the unconjugated bilirubin which is high. So it is not the conjugated bilirubin as seen in Dubin-Johnson syndrome. Therefore, urine dipsticks test would be normal here. So we have to remember viral infections are common triggers for a rise in the bilirubin in patients with Gilbert syndrome. So as we can see here in this chart, Gilbert syndrome is an autosomal recessive disorder due to decreased UGT enzyme causing unconjugated hyperbilirubinemia. Features are jaundice with stressors such as infection, surgery, dehydration, fasting, mildly increased unconjugated bilirubin, third, normal reticulocyte and LFTs, and symptomatic management. So again, Gilbert syndrome is an autosomal recessive disorder, common cause of unconjugated hyperbilirubinemia due to decreased UGT1 activity, which is the enzyme for the conjugation of bilirubin with glucuronic acid. This enzyme UGT1 helps in conjugation of bilirubin with glucuronic acid. There is decreased activity of this enzyme, which leads to unconjugated hyperbilirubinemia, and it is an autosomal recessive disorder, that is Gilbert syndrome. And it usually presents in adolescents with intermittent jaundice during stresses such as any kind of illness, physical exertion, stress, or fasting. Here it was precipitated by infection, and investigations usually show mildly raised serum bilirubin, whereas the other LFTs are normal. reticulocyte count is normal, which helps in distinguishing Gilbert syndrome from the other types of hemolysis. In other types of hemolysis, reticulocyte count is not normal. In Gilbert syndrome, reticulocyte count is normal. Here, urine dipstick test would be normal as well, because in Gilbert syndrome there is unconjugated hyperbilirubinemia, not conjugated hyperbilirubinemia. So it is not like there is no conjugated bilirubin as seen in Dubin-Johnson syndrome. Therefore, urine dipstick test is also normal. Viral infections are common triggers for rise in the bilirubin in patients with Gilbert syndrome. Autosomal recessive disorder due to decreased UGT enzyme causing unconjugated hyperbilirubinemia. Features are jaundice with stresses such as infection, dehydration, fasting, surgery. Mildly increased unconjugated bilirubin. Unconjugated hyperbilirubinemia, mildly increased unconjugated bilirubin, normal reticulocyte, normal LFTs, and symptomatic management. So that is about Gilbert syndrome. Let's move further. A 33-year-old lady who has been traveling around Europe for a few months now returns to the United Kingdom with lethargy, abdominal pain, loose, watery diarrhea, and bloating. She has lost a few kilograms since coming back from the trip. Her physical examination remains unremarkable, with abdominal examination having mild generalized tenderness. What is the single most likely organism causing her symptoms? So, there is a history of travel, and we see abdominal pain, loose, watery diarrhea, bloating is there, lethargy is there, weight loss is also there, and there is mild generalized tenderness in the during the abdominal examination. So now we have to study about giardia. Giardia lamblia, and so the top choices for the causes of diarrhea are Campylobacter and Giardia lamblia in this case. Now, as the patient has watery diarrhea instead of bloody diarrhea, so Giardia fits best. Because basically E. coli is the most common cause of traveler's diarrhea globally, which occurs in less than 3 days. But because it is not mentioned here, so that would not be the case, that would not be the answer. In the UK, many cases of giardiasis are associated with a recent foreign travel. Giardiasis can present as traveler's diarrhea, with symptoms lasting more than 10 days. Symptoms of giardiasis include bloating, flatulence, abdominal pain, loose stool, explosive diarrhea. The symptoms may begin after returning from travel and may be associated with weight loss. Giardiasis can cause both acute and chronic diarrhea. And this stem, it is likely that chronic diarrhea is there as there is a history of weight loss. The clinical features of giardiasis are slightly different compared to Campylobacter enteritis. In Campylobacteriosis, clinical features usually include a prodromal illness of headache and myalgia with fevers as high as 40 degrees Celsius. Now, this is followed by abdominal pains and profuse diarrhea. The stool is often bloody. The reason many chose Campylobacter as the answer here is because Campylobacter is the commonest bacterial cause of infectious intestinal disease in the UK, but it is not the case here. Campylobacter, Shigella, Salmonella. They usually cause bloody diarrhea. Giardiasis causes non-bloody diarrhea. Giardiasis can cause chronic diarrhea associated with weight loss. Campylobacter has a prodromal illness or has prodromal symptoms like headache, myalgia, and fever. So here, as we see, let's study a little more about giardiasis. Giardiasis is a parasitic infection caused by Giardia lamblia, which is transmitted commonly by the fecal-oral route. So, contaminated water, ingested food, contaminated swimming pool, or by ano-oral sexual transmission. Now, most cases are associated with foreign travel, particularly in countries where there is poor sanitation. Presentation: there is watery diarrhea lasting over a week, foul smelling flatulence, nausea and belching, abdominal pain, and fever may be present or may not be present. Diagnosis is by stool microscopy, which is the first line, then stool PCR or ELISA. Treatment is rehydration, hygiene, metronidazole or tinidazole. So again, giardiasis. So again, giardiasis is a parasitic infection caused by Giardia lamblia, which is transmitted by fecal-oral route most commonly. That is contaminated water, contaminated food, contaminated swimming pool, or by ano-oral sexual transmission. Most of the cases are associated with foreign travel, particularly in countries with poor sanitation. Presentation of giardiasis would be there is watery diarrhea lasting over a week. There will be flatulence, that is foul smelling flatulence, then nausea, belching, abdominal pain, and presence or absence of fever. Diagnosis is done by stool microscopy, that is the first line, then stool PCR or ELISA. Treatment is by rehydration, taking care of hygiene, and metronidazole or tinidazole. So the top two choices for the causes of diarrhea here can be Campylobacter and Giardia, but because it was watery diarrhea, so Giardiasis is more likely the answer because there is no bloody diarrhea here. In the UK, many cases of giardiasis are associated with recent foreign travel, and this giardiasis can present as traveler's diarrhea with symptoms lasting more than 10 days. Symptoms of giardiasis are bloating, flatulence, abdominal pain, loose stool, explosive diarrhea. It can this watery diarrhea can be explosive as well. Symptoms may begin after returning from travel and may be associated with weight loss. So, giardiasis can cause both acute as well as chronic diarrhea. Here, because there is a history of weight loss, so it is more likely that it is a case of chronic diarrhea. The clinical features of giardiasis are slightly different as compared to Campylobacter. In Campylobacteriosis, we have a prodromal illness. In Campylobacter infection, Campylobacter enteritis or Campylobacteriosis, we have a prodromal illness having symptoms such as headache, myalgia, and fever as high as 40 degrees Celsius. This is followed by abdominal pain and profuse diarrhea, and the stool is often bloody. So, we often have bloody diarrhea there. And it is the commonest bacterial cause of infectious intestinal disease in the UK. Campylobacter jejuni. It is the commonest bacterial cause of infectious intestinal disease in the UK. So, Campylobacter, Shigella, Salmonella, these are the three causes usually causing bloody diarrhea. They are usually causing bloody diarrhea, and Giardia causes non-bloody diarrhea. Giardia can cause chronic diarrhea associated with weight loss. Campylobacter has a prodromal symptoms of headache, myalgia, and fever. Let's now go through the chart here. So as we can see here, we have two categories, watery diarrhea and bloody diarrhea. Watery diarrhea, traveler's diarrhea. Traveler's diarrhea is watery diarrhea caused by E. coli, then rotavirus causing watery diarrhea in children, giardiasis causing watery diarrhea, malabsorption, abdominal pain, bloating, weight loss. Treatment of giardiasis is metronidazole or tinidazole. Staphylococcus is causing diarrhea immediately after a meal, that is preformed toxin. Then cryptosporidiosis causes watery diarrhea in HIV and other immunocompromised patients. Treatment is nitazoxanide and HART. Now, in case of bloody diarrhea, we have Campylobacter causing GB syndrome, that is Guillain-Barré syndrome. E. coli causing hemolytic uremic syndrome, Salmonella in poultry, and amoebiasis. Pseudomembranous colitis caused by Clostridium difficile causes diarrhea after antibiotic such as clindamycin or amoxicillin. Treatment is oral vancomycin, should be the first line drug. This so gastroenteritis, uh, we have two categories, watery diarrhea and bloody diarrhea. Watery diarrhea is having different causes. First, traveler's diarrhea, which is caused by E. coli. then rotavirus causing watery diarrhea in children, then giardia or giardiasis caused by giardia lamblia. Giardiasis causes bloating, abdominal pain, weight loss, malabsorption, and watery diarrhea. Here, the treatment in giardiasis is metronidazole, then staphylococcus. Staphylococcus causes diarrhea, watery diarrhea right after meal, therefore, there is preformed toxin. Staphylococcus in this diarrhea is immediately caused after a meal. That is preformed toxin is there. Then cryptosporidiosis, it causes watery diarrhea in HIV patients and other immunocompromised patients, and the treatment is heart therapy and nitazoxanide. Nitazoxanide. So treatment of cryptosporidiosis that is causing watery diarrhea in HIV patients and other immunocompromised patients is heart therapy and nitazoxanide. Now, bloody diarrhea. Bloody diarrhea is caused by Campylobacter. As we studied, Shigella, Salmonella also causes bloody diarrhea. So here, causes are Campylobacter causing GB syndrome, Guillain-Barré syndrome, and E. coli can also cause bloody diarrhea, causing hemolytic uremic syndrome. Then we have amoebiasis and salmonella. Amoebiasis can also cause bloody diarrhea. Salmonella and Shigella that we studied. Salmonella in case of poultry. Another thing is pseudomembranous colitis that is caused by Clostridium difficile. In this, there is diarrhea after taking antibiotics such as clindamycin or amoxicillin. Therefore, treatment is by oral vancomycin, which is the first line drug here. Okay, so let's move further now. So now a 28-year-old woman has a recent liver screen for hepatitis as her liver function was seen to be elevated. The last liver function test shows bilirubin 29, ALT 1020, AST 250, alkaline phosphatase 194. Liver screening results are hepatitis A IgG positive, hepatitis B and C antibody negative. On further questioning, she has had a recent episode of fatigue, tiredness several weeks ago, followed by muscle aches. She also feels a dull ache on the right upper quadrant of her abdomen. On examination, her skin appears yellow. Her observations are within normal limits. Which of the following is the most appropriate antibody level to view based on her liver screen results and symptoms? So now here we have to study about hepatitis A. The most important value to concentrate here is the hepatitis A virus IgG antibodies which are positive. This could mean either a recent infection or an infection that has been present for several years. The next antibody to view would be IgM antibodies for hepatitis A, as this would indicate if there is a recent infection. IgM antibodies to hepatitis A virus are detected around the time when symptoms develop, as opposed to IgG antibodies, which are detectable soon after IgM and they can remain detectable for several years. In the case of viral hepatitis, ALT is much higher than AST, although both are elevated. This is seen in the first liver function test that was arranged. So, in case of viral hepatitis, always ALT is much higher than AST. So, basically, IgM antibodies are detected around the time when the symptoms develop. So it shows the patient had, if we see IgM antibodies of to hepatitis A virus to be positive, it means recent episode, and there is fatigue, tiredness, muscle ache, prodromal symptoms. But IgG antibodies, they appear right after IgM antibodies, but they can persist. So the presence of IgM antibodies can mean either recent infection or an infection that has been present for several years, because they can remain detectable for several years. And in viral hepatitis, always ALT is much higher than AST, and both are elevated. Okay, let's study about hepatitis A. Here, in hepatitis A, mode of transmission is fecal-oral route. Clinical features: pruritus, that is nail or scratch marks, may be observed on the abdomen or limbs, so itching is there. Fever may not always be present. Prodromal symptoms such as myalgia and arthralgia can last 2 to 3 days. Then there is icteric phase, consisting of dark urine, pale stool, jaundice, and abdominal pain. There is tender hepatosplenomegaly. Then investigations here would be, in case of viral hepatitis, ALT and AST both are often elevated, with ALT AST ratio of more than 2. So ALP is elevated, alkaline phosphatase is also elevated along with ALT and AST. Bilirubin is elevated. Anti-hepatitis A virus IgM antibodies are detected around the time when symptoms develop. Then anti-hepatitis A virus IgG antibodies are detectable soon after IgM and remains detectable for life, for years, for several years. The presence of IgM irrespective of the patient's IgG status indicates an acute infection, recent infection, of an isolated IgG the presence of an isolated IgG implies that the patient had been infected in the past. If IgM antibodies are absent and only IgG antibodies are present, so it implies that the patient had infection in the past. Now we'll see about management. Management is supportive management with fluids, antiemetics, which are the mainstay of management and useful in majority of the cases. Hospital admission is required if the patient is systemically unwell. Hepatitis is a notifiable infection. Public Health England must be informed of the same. So, hepatitis A, the mode of transmission is fecal-oral route. Clinical features are pruritus or itching, so there will be nail or scratch marks on the abdominal limbs. Fever may not always be present. Prodromal symptoms are present, such as myalgia and arthralgia, which can last for 2 to 3 days. Icteric phase, that is dark stools, dark urine, pale stools. In icteric phase, there is dark urine, pale stools, jaundice, and abdominal pain. Then there is tender hepatosplenomegaly. So, again, pruritus or itching, nail scratch marks of the abdominal limbs. Fever may or may not be present. Prodromal symptoms such as myalgia, arthralgia lasting for 2 to 3 days. Icteric phase, dark urine, pale stools, jaundice, abdominal pain, and tender hepatosplenomegaly. These are the features of hepatitis A. Investigations: ALT raised more than AST, ALT AST ratio more than 2, alkaline phosphatase is also raised, bilirubin is raised, then IgM anti hepatitis A virus antibodies. So IgM antibodies are detectable around the time when symptoms develop. Then anti hepatitis A virus IgG antibodies are detectable soon after IgM, but they remain detectable for life for several years. Presence of IgM, irrespective of patient's IgG status, indicates an acute or recent infection, whereas the presence of an isolated IgG tells that the patient had infection in the past. Management: supportive management with fluids and antiemetics. It is the mainstay of the management and will be sufficient in majority of the cases. Hospital admission only required if the patient is systemically unwell. It is a notifiable infection. Hepatitis is a notifiable infection. Public Health England must be informed of the same. Okay, so let's move further now. Now, a 75-year-old man presents with difficulty in swallowing both solids and liquids. While he admits to having a mild and more bearable difficulty in swallowing for the past 3 years, his symptoms has worsened over the past 2 weeks, and he has been unable to eat or drink since yesterday despite maintaining a good appetite. He was diagnosed with esophageal cancer 1 year ago. which had metastasized to liver and lungs at the time. Additionally, he reports that he lost 2 kgs of blood, 2 kgs of body weight since the time of diagnosis. Provided the stage of cancer and the age of the patient, surgery was not a feasible option. He understands the implication of his diagnosis, which is to live in comfort for the remainder of his time. What is the most appropriate management of this patient? So now we have to study about stenting, that is esophageal stenting, which we'll study in a while. Let's take a break. Be back.